So, hello everyone, welcome to the second part of chapter 2, Cell Injury and Cellular Adaptations. Let us continue the rest of the topics. Here we are going to start with some recap of the previous session. Necroptosis and pyroptosis. Remember, in necroptosis, we have RIPK1, RIPK3, and in pyroptosis, we have Cas1, Cas11, interleukin 1. And here I have told you a very high yield point. What is that? Gas dermin. Am I right? I hope you remember gas dermin decleavage takes place in pyroptosis. Okay, it's a potential question. Okay, they have asked in INISET once. Fine. So let us start about autophagy. See, autophagy is an 10th edition update. It's a 10th edition update. So those who are following the old edition, please take a note of this carefully. Autophagy means the cell is going to eat its own content. Auto means self, phagy means eating. Why this autophagy is important? Because it is implicated in many physiological states like aging and exercise, as well as in many pathological states like cancer, all those. What are the steps in autophagy? Please go through the picture. There will be initiation, elongation, formation of autophagosome, fusion with lysosome to form phagolysosome, finally degradation. These are the various steps of autophagy. If you write these steps in the form of a flowchart, please always present things in flowcharts like this. Okay? Yes, it will help you to really fetch more marks rather than normal paragraph writing. Okay. Here we have formation of vesicle, am I right? And maturation of autophagosome, and finally phagolysosome, that is at fusion, and finally what? Complete clearing of the debris. So this is actually autophagy. The genes which are involved in autophagy, we call it as ATG, that is autophagy related genes. As I have told you last class, we have annexin 5. The annexin 5 is actually, okay, the annexin 5 is actually for apoptosis, am I right? Intrinsic pathway marker, apoptosis. Similarly, for autophagy, we have a marker that is called as protein light chain 3. LC3, this is a marker of autophagy. Again, it is a potential MCQ question. Fine. Okay. So that is a marker for autophagy. Okay. So that finishes here. Then we have some diseases where this autophagy is implicated. Number 1, cancer. As a result of autophagy, the autophagy, it can be directed against the cancer cells. So this autophagy, as a result of autophagy, the cancer cells will start dying. Number 2, in neurodegenerative disorders like Alzheimer's disease and Huntington's chorea. Then in infectious diseases like Mycobacterium, Shigella and HSV1, which you will learn in microbiology, you will read in detail. And inflammatory bowel disease. Yes, this has been an AIMS MCQ question, AIMS PG entrance exam question. That is, autophagy related gene 16L1 has been implicated in an inflammatory bowel disease. We call it as Crohn's disease. We have another one called as UC, ulcerative colitis and Crohn's disease. Both are a group of, together we call it as the inflammatory bowel diseases. Okay, in that, this has been a question. Which of the following genes has been implicated in the pathogenesis of Crohn's disease? Answer is ATG16L1. Okay, this has been an AIMS previous year question. Already they have asked this question. Okay, fine. So just remember those important points. Some high yield. High yield means, yes, those who are aiming for stars, or we can say this as nerd corner. Okay, nerd corner. Still not satisfied. I need still more. Yes, for those, please listen. Again, autophagy means self-eating. Physiological autophagy seen in aging and exercise. Pathological autophagy, I have told you, in cancer, Alzheimer's and Huntington's disease, infectious diseases. And here a very, very important question they have asked. Okay, this is again an MCQ question. Again, this has been asked in INSET. Which autophagy related gene is related to increased susceptibility to tuberculosis? The answer is ATG5. ATG5 deletion. I'm writing here ATG5 deletion. Deletion means mutation. leads to increased susceptibility to TB. Those persons, people who are having this ATG5 mutation have increased susceptibility to TB. And of course, inflammatory bowel disease, I have told you, what is the name of the gene? ATG16L1 in Crohn's disease. Inflammatory bowel disease, specifically Crohn's disease. Okay, LC3, that is protein light chain 3, is the useful marker for autophagy. Okay, and there is a first process, I have told you in this picture, there is a process, that is nucleation. Okay, first there will be a formation of a nucleation complex that is responsible for the initiation of autophagy. This nucleation is actually started by a protein called as Beclin-1. What is that? Beclin-1. Okay, please remember that. What are the different types of autophagy? We have chaperone mediated, okay, that is through chaperone proteins, okay, through chaperone proteins. We have something what we call it as micro-autophagy, inward invagination of lysosomal membrane. Macro-autophagy, that is actually via autophagosome. I have explained one picture, one flowchart, that is this. Yeah, this is actually an example of macro-autophagy. Okay, macro-autophagy. Just to go through this high-yield facts. Okay, I hope that is clear. Okay, you may get any question in Central Institute's exams. You may get some questions. Fine. Let us see what are the mechanisms of cell injury. Various mechanisms. Okay, the cell injury. What is actually responsible for this cell to undergo morphological changes in necrosis or apoptosis? Okay, yes. Okay, here I am going to see what is just the points. Okay, I am not going to read line by line, because if I will what I have highlighted, that is the headings. You just elaborate that. Okay, using those headings you can write up to 1 or 2 pages for a short note question. Sometimes they will ask what are the mechanisms of cell injury, please explain. Okay, in such a question usually won't ask, it's just for your basic understanding, but if they ask you can elaborate using this hints. Okay, I'm going to just say the hints. Fine. So first, okay, there will be mitochondrial damage, there will be membrane damage, there will be DNA damage. Okay, these 3 damages. Remember 3 damages, children. Okay, number 1 is what we call it as mitochondrial damage. Number 2 is what we call it as membrane damage. Number 3 is DNA damage. These are the 3 major mechanisms of cell injury. We are going to see them one by one. Mitochondria is the critical player in all pathways leading to cell injury and death. We have seen them in intrinsic pathway of apoptosis. Yes. What are the major consequences of this mitochondrial damage? There will be ATP depletion. Okay, and there will be why there is ATP depletion? Because of ischemia or hypoxia. Fine. The activity of sodium potassium pump will be reduced, cellular energy metabolism is altered, and the glycogen stores will be depleted, reduction in protein synthesis. So these are the consequences of mitochondrial damage. No need to read the stories, pa. We have pictures. I told Robbins always focus on pictures and tables. That will give you everything. See, mitochondrial damage. Ischemia, hypoxia, radiation, or any injurious stimulus. Decrease in ATP, decrease in energy, cell injury, necrosis. Increase in ROS, reactive oxygen species, free radicals. I will tell soon. Damage to lipids, protein, lipid peroxidation, everything happens, necrosis. Whenever there is other injurious agents. Next I am going to explain about membrane damage. Damage to lysosomal membrane causing leakage of enzyme, damage to plasma membrane leading to impaired transport function, finally leading to necrosis. DNA damage like radiation mutation, cell cycle will be arrested, caspase will be activated, finally leading to apoptosis. These are, if you draw these 3 pictures, that's more than enough. There is no need that you have to mug up and write all those points. Again, we will go, I have told what happens when there is mitochondrial damage, decreased oxygen, mitochondrial dysfunction, decrease ATP, increase ROS, necrosis. Whenever there is increased pro-apoptotic or decreased anti-apoptotic, leakage of mitochondrial protein, finally apoptosis. That is what we have learned in intrinsic pathway of apoptosis. Yes, I hope things are clear for you. Okay. Just focus on the key points. These are all very basics. Okay, if you can, there is no need that you have to sit and read each and every line to understand these things. These are all basics. Okay, fine. Okay. Coming to membrane damage, I have already told you here what is happening in membrane damage. Let us see with the help of a picture. Membrane damage. Fine, let us see with the help of a picture. Decreased oxygen, increased ROS, causing lipid peroxidation, decreased phospholipid synthesis, increased calcium causing phospholipase protease activation, lipid breakdown products will be increased, cytoskeletal damage, phospholipid loss, finally leading to membrane damage. Just the picture itself you can understand. Then damage to DNA causes P53 dependent pathway activation. Just remember that single point. What is P53? What are P53 dependent pathways? Everything we are going to see. Everything we are going to see in chapter 7, neoplasia. It's like an ocean. Okay, there we are going to see only signaling pathways, signaling molecules. That is the single thing we are going to discuss there. Okay, I hope things are clear for you. Okay. Now let us see about the free radicals. Free radicals or the reactive oxygen species. Those students who feel difficult with these free radicals, okay, please, I will ask you to refer biochemistry. Biochemistry, what? Pankaj Naik. Biochemistry, Pankaj Naik. Please go through the chapter free radicals. Everything is very beautifully mentioned there. Okay, yes. What are free radicals? You know. Fine, yes. How the free radicals are generated? Number 1, through redox reaction. Number 2, absorption of radiant energy. Number 3, during inflammation. Number 4, enzymatic metabolism of chemicals. Number 5, transition metals. Here comes a very important MCQ question. Okay, what is Fenton's reaction? They will give a reaction and they will identify. Fenton's reaction means hydrogen peroxide plus Fe2 plus will leads to Fe3 plus OH minus plus hydroxy free radical. Okay, yes. Here I have given a table. Okay, it's mentioned Robbins. That is peroxide, hydrogen peroxide, peroxynitrite, hydroxy. Out of that, the most reactive oxygen free radical is. This is an MCQ. The most reactive or the most powerful. The most powerful ROS, reactive oxygen species, is our hydroxy free radical. Okay, I hope it is very clear for you. Okay, then see how the production from superoxide, hydrogen peroxide, hydroxy radical. Okay, and finally these free radicals will have some pathological effect. Lipid peroxidation, which leads to membrane damage. Protein modification leads to protein misfolding, and in DNA it will cause some mutations. Fine, okay. Free radicals may be asked. So when the free radicals are asked as a short note, first write what is free radical, how they are generated. Then number 2, draw these two pictures. Then how the free radicals are normally removed, and finally what are the pathological effects of free radicals. How they are normally removed? Antioxidants we have vitamin E, vitamin C. Okay, yes, all those are there. Fine, yes. They are free radical scavengers. Fine. Then we have enzymes like catalase, superoxide dismutase, glutathione peroxidase. Okay, all those. So all these things already learned in biochemistry. I am not going in detail. What it is going to lead? Again, it causes lipid peroxidation in membranes. Okay, what is the mechanism of free radical injury? That is again mentioned in your Pankaj Naik biochemistry book. Then oxidative modification of proteins leading to protein misfolding, and finally in DNA it will causes mutations. Fine. I told you that calcium is a very important culprit because it serves as a signaling pathway. It serves as a second messenger for many signaling pathway. What is this calcium going to do? See, whenever there is an injurious stimulus, the extracellular calcium will come inside the cell and in the cell we have mitochondria and endoplasmic reticulum. So finally, as a result of injury, there will be increased cytosolic calcium, which will increases mitochondrial permeability and a decrease in ATP. Activation of enzymes like phospholipase, protease, endonuclease and ATPase. So endonuclease will causes nuclear damage, whereas the rest of the two will causes membrane damage. So just draw the pictures. See, just focus on the pictures. Robbins means pictures, tables. Okay, remember this as a dictum. Okay, then it will be very easy for you to understand rather than going for the normal reading, routine reading. Fine. Then coming into what is ER stress. Yes, ER stress can be asked as a short note question. What is unfolded protein response or the endoplasmic reticulum stress? Normally, the proteins will be folded with the help of some other proteins we call it as chaperones or chaperones. In first class cell unit of health and disease, I have already explained it. Sometimes, due to some mutation, false or defective proteins will be formed. And these proteins will undergo accumulation, and normally it will be removed by the endoplasmic reticulum. If this unfolded protein or the defective proteins are very huge in amount, the endoplasmic reticulum cannot clear it because it exceeds the capacity of the endoplasmic reticulum. It will undergo accumulation to form, and that stress is finally what we call it as endoplasmic reticulum stress or ER stress. It is actually that is the inability of the endoplasmic reticulum to cope up with this stress. We call it as ER stress or unfolded protein response. Okay, I hope it is clear. Yes. Okay, and we normally the proteins are degraded by a group of proteins, we call it as proteosomes. Chaperones helps in protein folding, whereas ubiquitin and proteosomes, they mainly help in protein degradation. Fine. Okay, I will explain this in a high yield fact here. Okay, what is ER stress? See, misfolded proteins reaches the endoplasmic reticulum lumen. There will be increased synthesis of chaperones, reduced protein synthesis, increased degradation. All those will reduce the load of misfolded proteins. This is a normal unfolded protein response. Suppose if this stress is so severe, what will happen? There will be activation of BH3 proteins. You know where is BH3 proteins? They are the sensor proteins. Am I right? Yes, they are the sensor proteins. Am I right? Okay, they are the sensor protein. Then caspase will be activated. Finally, what is the fate? That is apoptosis. Okay, yes. So you can just focus on this picture. Just write this picture: endoplasmic reticulum stress or unfolded protein response. Okay. Once that is done, children, yes, see, this is another picture, very beautiful picture. Normally we have chaperones, okay, which causes mature folded proteins. Whenever there is metabolic alterations, viral infection, chemical stimulus, excess misfolded proteins will be formed. So the protein folding demand will be more than that of the capacity, which will lead to failure of adaptation or apoptosis. Sometimes the cell will try to adapt. How? By decreasing the protein synthesis and increasing the chaperones production, which leads to mature folded protein. Then this adaptation cannot occur. When there is failure of adaptation, we call it as unfolded protein response or ER stress, or which finally leads to activation of caspases and BH3 sensors, okay, finally which leads to apoptosis. Yes, here comes the question. You can watch an Instagram, okay, you can watch my Instagram reel over this disease caused by misfolding of protein. I am writing my Instagram account here, Nitin_Krishnan_PS. Okay, this is my Instagram page. Okay, this is my Instagram page. You can refer. Okay, I have done a reel on this table revision. Not only this table, all tables and Robbins right from first chapter. Okay, you can go through that. Okay, in cystic fibrosis, we have cystic fibrosis transmembrane conductance regulator. CFTR gene is a protein problem. So loss of CFTR leads to defect in chloride transport. Familial hypercholesterolemia, as you have already studied in biochemistry, it is LDL receptor. Loss of LDL receptor leads to hypercholesterolemia. Tay-Sachs disease, hexosaminidase beta subunit is released, which leads to accumulation of gangliosides. Alpha-1 trypsin deficiency, in alpha-1 trypsin is absent, so what will happen? It will causes emphysema, as well as it may causes destruction of hepatocytes. Creutzfeldt-Jakob disease caused by prions, okay, and there will be abnormal form folding of PRPSC. What is PRPSC? Prion proteins, okay. SC stands for scrappy, okay, yeah, scrappy. And Alzheimer's disease, there will be accumulation of A beta peptide, which leads to abnormal folding of A beta peptide, which causes aggregation. Okay, A beta misfolded proteins will start accumulating within the neurons, leading to neuronal damage, and the patient will have memory loss, because it is mainly going to affect the neurotransmitter acetylcholine. Fine. Yes. So these are the examples of disease which are caused mainly by the misfolding of proteins. Okay. Then coming into hypoxia and ischemia. So I hope it is very clear for you. Yes, I hope it is very clear for you. Okay. Hypoxia and ischemia. What is the pathogenesis? What is ischemia? Decreased blood flow, which finally leads to hypoxia. Whenever there is an ischemia, fine, whenever there is an ischemia, decreased oxidative phosphorylation, decreased ATP, decreased sodium potassium pump, ER swelling, cellular swelling, all our usual story, decreased glycogen, increased lactic acid, clumping of nuclear chromatin, decreased protein synthesis. These are the fate. Just go to these pictures. Fine? Yes. Okay. I told you that we have a protective response to deal with this hypoxia. For example, I am traveling to Himalaya. I am in a mission to conquer the Mount Everest. So I am traveling high up the mountains. Fine. What will happen? Low oxygen tension in high altitude. Hypoxia I will undergo. But whether I am going to fell down there immediately, most of us know why. We have some adaptive response. We call it as acclimatization. Yes, what is that adaptive response? We have something called as hypoxia inducible factor 1, which will enhance new blood vessel formation. Just remember this point. When new blood vessels get formed, automatically the blood will reaches that particular organ. We will be all right. Yes, okay. Here comes a very important short note question. What is ischemia reperfusion injury? It is a short note question, children. It will be again discussed in our cardiovascular system pathology chapter. What is ischemia reperfusion injury? Ischemia reperfusion injury. Normally, a organ is under ischemia. But somehow, through adaptive response, the blood reaches back to that organ. But still, the injury becomes more severe. How? We are going to see. So, the restoration of blood flow to ischemic tissue can promote recovery of cell if they are reversibly injured, but it can also exacerbate the cell injury and cause cell death. That means, as a result of reperfusion, that is original blood supply, when the blood supply is restored, the injury is much more severe than before. This is called ischemia reperfusion injury. It is very important for myocardial and cerebral infarction. How this occurs? Various theories has been put forward to explain this. Oxidative stress. That means what the authors are telling, when the blood supply is restored, there will be increased generation of reactive oxygen and reactive nitrogen species. Free radical will cause injury. Number 2, whenever there is reperfusion, there will be more influx of calcium into the sarcoplasmic reticulum, which will further causes ATP depletion and further cell injury. What is the other thing? Inflammation. There will be some danger signals which will be released from the injured cell, and when this blood supply is restored, it will be further exaggerated, which will causes what? More inflammation, and it will release further cytokines, which will finally leads to more cell injury. Again, this we will discuss in chapter 3, inflammation. And finally, activation of complement system, which will further contribute to ischemia reperfusion injury. The MCQs are not like this. MCQ examiners are very smart than us. They are asking which is the most accepted theory. Most accepted theory for ischemia reperfusion injury. Only one answer, children, that is ROS. That is reactive oxygen species or free radicals theory. Free radicals theory. I hope it is very clear for you, all of you. ROS, free radicals theory. This is an MCQ question. That is how. That is the difference between normal our university exams and the MCQ exam. They are always smarter. Fine. Then we have chemical or toxic injury. Okay, that and all not that much important. You have read about cytochrome P450 enzyme system. Now we are seeing about what are the cellular adaptations. Remember, adaptation means they are reversible changes. When the cell is under stress, it will try to adapt to become normal. What are such adaptations? Number 1, we have hypertrophy. Number 2, we have hyperplasia. Number 3, we have metaplasia. Number 4, we have atrophy. Hypertrophy means increase in size of cells. Each word is important. Increase in size of cell is called as hypertrophy. Okay, yes. When you go for gym or fitness center, what you are going to increase the bulk or mass of your muscles. That is actually hypertrophy of your muscles. It may be either physiological or pathological. Fine. Where you can see physiological hypertrophy. Here comes the MCQ question. Which of the following is an example of physiological hypertrophy? Which of the following is an example of physiological hyperplasia? All these are questions. Uterus during pregnancy is a good example of hypertrophy, okay, of smooth muscles. Fine. Uterine hypertrophy, it is an example of physiological hypertrophy. Okay, there are some controversies with this. Sometimes in some books they are telling uterus have both hypertrophy as well as hyperplasia. All those controversy I will write separately, and I will send it separately. So as of now, follow Robbins, what it is mentioned. First you make it thorough. Uterine hypertrophy, uterus during pregnancy is an example of physiological hypertrophy. Okay, yes. The bulging muscle, okay, the bulging muscle of bodybuilders, no, yes, that is again an example of physiological hypertrophy. Pathological hypertrophy, the most common stimulus for hypertrophy of skeletal and cardiac muscle is what? Increased workload. The best example you can go for is what we call it as cardiac hypertrophy. Okay, we have a condition what we call it as ventricular hypertrophy. That is, the ventricle of the heart will be hypertrophied. Ventricular hypertrophy. Okay, we have pictures, we will see that again. It is an example of pathological hypertrophy. Why this hypertrophy occurs? It is result of, am I right? When you go to gym, what the fitness trainer will advise you? Take more proteins, eat more pulses, okay, eat more meat and meat products, so that it will increase your protein intake, so that your muscles will get more bulk. So result of increased cellular protein production. Fine. And the pathway is Pi3 Akt pathway. Just remember the name of the pathway, Pi3 Akt pathway. What is this pathway? Again, we will see in Neoplasia chapter. No worries. Just to remember this point. Pi3 Akt pathway. Fine. See, you can see here. This is the normal uterus, and this is the physiological hypertrophy of the uterus during pregnancy. Am I right? Yes. So this is again the normal uterus, histopathological or microscopy. And here you can see here, you can't appreciate whether it is a uterus. The cells are elongated. Okay, this is again the microscopic appearance of physiological hypertrophy of uterus. Fine. Yes. See, this is the pathway. Okay, cardiac hypertrophy, I have already told you. So what are the stimulus? There may be mechanical stretch, there will be growth factors, agonist, all this will activate this various pathway, GATA4, NF80 and MEF2, which will finally leads to increased synthesis of proteins and production of growth factor, which will increase the mechanical performance at last. So remember what is the main pathway here? Pi3K/Akt pathway. We also have other pathways like GATA4, we have another pathway called as NF80, we have another pathway called as MEF2. Don't ask me, sir, what is this, because I also don't know. Okay, yes. Because it's nowhere mentioned in the books like what are this pathway in detail. Pi3K/Akt pathway, okay, this pathway alone. Okay, Pi3K/Akt pathway, this chapter, this thing alone we will learn in Neoplasia. Rest of the things we have to by heart. Yes, in pathology, lot of things we don't have further explanation. don't have any further evidences to demonstrate what it is. We are going to just remember those names, no other way. Okay, yes. Okay. Can you, okay, we are telling no, renal artery is having so and so branches, abdominal aorta is having so and so branches. Okay, is there any evidence to support? Okay, of course, if we open our if we do any dissection specimens, everything, we can at least appreciate those. But in here, these are all molecular levels. Okay, we are speaking at very molecular level, we can't even imagine at all. So these factors and all you have to just remember. Okay, the most important one we will discuss somewhere, okay, in the due course. Coming into hyperplasia. Hyperplasia means increase in number of cells. We have again physiological hyperplasia as a result of hormonal actions. The best example is female breast at puberty and during pregnancy, which is because of the enlargement, that is, of the glandular epithelial cells. And the another best example of hyperplasia is liver regeneration. After liver transplant, the liver undergo regeneration. Okay, that is another very, very important example. Pathological hyperplasia, we have endometrial hyperplasia, which is an abnormal hormone-induced hyperplasia in chapter of MGT, FGT, that is female genital tract, male genital tract, we will see. And we have something called as BPH. Okay, BPH. What is BPH? It is benign prostatic hyperplasia, very important. I think in first year in textbooks, some textbooks like Vishram Singh and all, they have mentioned it is benign prostatic hypertrophy. No, it is not hypertrophy, it is hyperplasia, BPH. That's why I have written it separately. BPH is benign prostatic hyperplasia. Okay, yes. Then see, benign prostatic hyperplasia is another common example of pathological hyperplasia. Okay, yes. It doesn't mean hyperplasia is cancer. No. For saying that it is a cancer, we have lot of criteria which we will see in chapter neoplasia. This is an abnormal problem. It's actually an adaptation. Okay. Adaptation only happens in reversible injury. Irreversible injury, no. The time for what being adapted has already over. It will either go, it has two fates. Either it should undergo necrosis or it should undergo apoptosis. What are the features or mechanism? We have told, no, in hypertrophy we have what Pi3 Akt, GATA4, NFA2, okay, all those pathways we have told, no. Similarly, in hyperplasia we have growth factor driven proliferation, okay, of mature cells as well as by increased output from the new tissue stem cells. Okay, here actually what is happening, just remember one point. How to remember the mechanism of hyperplasia? Remember this one point: increased production of stem cells. Finally, these stem cells will lead to new tissue cells. This will lead to hyperplasia. Things are very clear for you, I hope. Fine. They will ask the mechanism in MCQ. What is atrophy? What is atrophy? Atrophy means reduction in size of an organ or a tissue, or decrease. So far we have studied hypertrophy means increase in the size, hyperplasia means increase in number, atrophy means decrease in size or decrease in number. Here we have physiological atrophy, that is notochord, thyroglossal duct, they all undergo atrophy during the fetal development. Pathological atrophy may be either disuse atrophy because of decreased workload. Suppose we are not using our body, we are sitting idle for some 10 years. What will happen? Our muscles will undergo atrophy, that is called as disuse atrophy. What is loss denervation atrophy? Suppose the nerve supply to my biceps brachii, that is a musculocutaneous nerve, is injured. So there is no nerve supply to this muscle. So this muscle will not be able to contract properly. That is called as, and as a result of it, it will undergo atrophy. That is called as denervation atrophy. Then as a result of diminished blood supply due to chronic ischemia, am I right? Yes. That is called as senile atrophy. Then inadequate nutrition, loss of endocrine stimulation due to pressure, all those will causes what? Decrease in size. That is what we call it as, atrophy. Fine. Okay. See this picture. This is a normal brain. This is a normal brain. You can see how far the sulci and gyri. This is a patient with an old man, very old man. Probably I can say he may be having Alzheimer's disease. Okay. Yes, you can see very deep sulci. Okay, and broad gyri. Okay, widely spaced. Okay, these are some of the features you can appreciate from this. Okay, this is again an example of atrophy. What is the mechanism of atrophy? Decreased protein synthesis or increased protein degradation. Here I told you the degradation of protein takes place mainly by using one pathway. What is that? Ubiquitin proteasome pathway. Okay, yes. Here we have a condition called as brown atrophy of the heart. What is the condition called as brown atrophy of the heart? Yes, brown atrophy of the heart. Brown atrophy of the heart. I will tell you what is brown atrophy of the heart. I will show you the picture. Actually, in brown atrophy of the heart, okay, brown atrophy of the heart, the brown atrophy of that, what is happening? Here also the heart will undergo atrophy. Yes, this is the characteristic picture you can see. See, you can appreciate. Okay, you can appreciate this picture. You can appreciate this picture. See, this is brown atrophy of the heart. That is what is happening here. One second, I will save here. Okay, see this picture. See this picture. Yes. What you are seeing, you can see that the heart is a little bit shrunken. Am I right? At the same time, you can see some brown pigment here. Brownish pigment you can see here. This is called as lipofuscin. Lipofusin, I will discuss very shortly. Lipofusin is also called as wear and tear pigment. Wear and tear pigment. Or it is also called as pigment of cell injury. Pigment of cell injury. Normally, under hematoxylin eosin H&E staining, it will appear like brownish or yellow brown in color. Yellow brown in color. That is lipofusin. That is what we call it as lipofusin. Okay, yes. So here you can see, lipofusin granules, brownish discoloration. Okay, when this will lead to brown atrophy of the heart. Okay, that is lipofusin granules. Okay, just remember this point. Again, it may be a potential. What is this lipoprotein? Sorry, what is it? It is an atrophy, brown atrophy of the heart. And what is the pigment? It is lipofusin. Okay. We have another condition called as metaplasia. What is the condition called as metaplasia? Yes, this is very, very important, children. This is very, very important, metaplasia. See, actually metaplasia means it is a reversible change. Okay, again, what all we have studied, it is reversible. Here, one type of cell is replaced by some other type of cells. For example, normally, what is the lining epithelium of our respiratory tract? It is columnar epithelium. Suppose I am smoking daily with 2 cigarettes a day. I am smoking for around 1 month. It is a stimulus. It is an injury. I am going to injure. Yes, I am injuring my epithelial cells. What will happen as a result? What is the mechanism behind metaplasia? Reprogramming of the stem cells. In hyperplasia, increased production of stem cell. Here, the reprogramming of stem cells occurs. As a result, my columnar epithelium will be gradually transferred, or it get transformed into squamous epithelium. This is called as squamous metaplasia. This is the most important confusion you will get. So the name of the metaplasia is determined by the fate. Finally, what it is becoming. Then we name like this. For example, here columnar is becoming squamous. So what is this metaplasia? We won't say it is columnar metaplasia. No, it is wrong. We will say it is squamous metaplasia. Next, we have a condition called as Barrett's esophagus. It is a pre-malignant condition. That means it is not a cancer. Okay, it's not a malignancy, but in future it may leads to malignancy. Barrett's esophagus, we call it as columnar metaplasia. Why we call it as columnar metaplasia? Because esophagus normally have squamous cells lining, but because of the injury, because of the reflux of acid, okay, that is the acid reflux is the injury here, it will become columnar. Or we call it as intestinal metaplasia. That means, for intestine, we have the columnar epithelium. That is why we call it as, so the lining has become similar to that of the intestine. We call it as intestinal metaplasia. So, whatever be the question they have given, how we will name the metaplasia? By the fate. Finally, what it is becoming, we will name accordingly. Okay, yes. And here comes the question, what is the most common metaplasia? Answer is squamous metaplasia. That means, initially columnar, it will become squamous. That is, especially in the cigarette smoker, all those things. Okay, yes. And the squamous metaplasia is also due to vitamin A deficiency, because vitamin A is responsible for maintaining the squamous epithelial cells. Whenever there is retinoic acid deficiency also, this has been it may lead to squamous metaplasia. This has been an MCQ. Okay, in names it has been asked once. What is the metaplasia? Okay, yes. Okay, then see metaplasia from squamous to columnar type, that is seen in Barrett's esophagus because of reflux of gastric acid. We have something what we call it as connective tissue metaplasia. Normally, what do you mean by connective tissue metaplasia? There, normally, this is also called as what we have something called as Myositis Ossificans. What is Myositis Ossificans? Okay, yes, I will explain what is Myositis Ossificans. Don't worry. See. Myositis Ossificans. Myo means muscle. Muscle undergo ossification to form bone. That means bone formation within muscle. Bone formation within muscle. Bone formation within muscle. Okay, yes, this is called as Myositis Ossificans. It is an example of connective tissue metaplasia. And remember, squamous metaplasia of lung predisposed. It is a pre-malignant condition. That means in future this condition may leads to lung cancer. Barrett's esophagus or Barrett's metaplasia, in future it may leads to esophageal cancer. Whereas Myositis Ossificans is not a pre-malignant condition. That means it won't give rise to any cancer of the muscles, or it won't give rise to any cancer of the bone. Okay, this is a very important. It's a triple star question. Okay, it's a triple star question. Which of the following is not a pre-malignant condition? You can straight away go with the answer Myositis Ossificans, which is not a pre-malignant condition. I have already told you what is the mechanism of metaplasia. Yes, it is the reprogramming of the stem cells. Okay, yes. I hope it is clear for you all. Yes, okay. So Myositis Ossificans, it's a potential question. Okay, it may ask in what AIIMS or AIIMS Central Institute exam, even in your next also, they may ask this question of Myositis Ossificans. That is ossification of the there is formation of bone within the muscle as a result of any intramuscular hemorrhage or anything. Okay, yes, this may happen. It is not a pre-malignant condition. Very important. Whereas Barrett's esophagus, rest of the conditions I have mentioned are pre-malignant conditions. Fine. Let us see some of the intracellular accumulation. Why there is intracellular accumulation? Due to inadequate removal, defect in packaging, failure to degrade, you have learned, no, lysosomal storage disorders, or due to some other substance. Let us see lipids. We have fatty change. I told you, fatty change is reversible or irreversible. It is a feature of reversible cell injury. Okay, what is the earliest feature of reversible cell injury? That is cellular swelling. Fine, yes. So, what do you mean by steatosis or fatty change? Both names are same. That means accumulation of triglyceride within the parenchyma, normally liver parenchyma. That is why we call it as fatty liver. Steatohepatitis, steatosis, all those usually refers to liver only. Fine. See, you can see in this picture, the normal, the livers are mainly filled with the large lipid bodies, right? Large lipid bodies. So this is a fatty liver. Remember, I am going to write here a very important question, and you are going to answer that. What are the stains you know for lipid? What are the stains you know for lipid? Yes, tell me. Oil red. Oh, very good. It will stain the lipids as red in color. Sudan black B. Okay, it will stain the lipid as black in color. And what is the another most important use of Sudan black B? It helps us in differentiating in hematology. Yes, very good. It helps in differentiating between myeloblast and lymphoblast. Myeloblast will be Sudan black positive. Lymphoblast will be Sudan black negative. Okay. Then, as a result of this accumulation, what may happen? We have lot of pathologies. It may cause us either atherosclerosis. Atherosclerosis means what? The cholesterol, it will undergo accumulation. Finally, this will be consumed by macrophages. And what are those called as formy macrophages, form cells? You have learned in biochemistry. No worries. Again, in detail, we'll learn in the cardiovascular pathology. Then we have what we call it as Sandomas. Sandomas are nothing else but the intracellular accumulation of cholesterol within the macrophages. Okay, and finally, there will be cholesterol deposition in the tendons and connective tissue, and we call it as Xanthomas. Okay, Xanthomas. See, even in our eyelid, upper eyelid. Yes, upper eyelid is one of the common site for Xanthomas. Okay, there will be yellowish like yellow white deposition you can see in the margins of the upper eyelid. That is actually Xanthomas. Or cholesterolosis. What is cholesterolosis? That is nothing else but the accumulation of cholesterol, mainly in the gallbladder. Cholesterol laden macrophages you can see here. See, you can see some white. Okay, you can see some white masses here. These are cholesterol laden macrophages. Cholesterol, the fat won't take stain. That is why it appears pale in color. It will be pale. Okay. Then coming into the proteins, we have lot of intracellular accumulation of proteins. Okay, yes. And one such protein, defect in protein accumulation, we call it as amyloidosis. What is amyloidosis? Don't worry, we will see what is amyloid, what is amyloidosis, everything in chapter 6, immune system disorders. Fine. Yes. And what else? Yeah, we have something what we call it as the Russell bodies. Russell bodies, I have told you last year itself, they are nothing else but the what? Intracytoplasmic. Russell bodies are intracytoplasmic inclusions of immunoglobulins. IG. I am writing IG immunoglobulins. Fine. Yes. Then of course we have aggregation of abnormal proteins. We have no protein aggregation disorders. Everything I have already told you. Fine. Yes. That cystic fibrosis, Alzheimer's disease, all those know what is happening. Abnormal proteins will undergo accumulation. You can mention all those here also. What do you mean by hyaline change? Hyaline change means there will be an alteration in the normal architecture of the cell, which will finally give rise to a homogeneous glass pink appearance in the histologic session. It may be either due to intracellular hyaline, okay, like accumulation of protein, Russell bodies, alcoholic hyaline, everything. Alcoholic hyaline, and we will see in chapter liver, no worries. Or it may be extracellular hyaline, which may be either which is very difficult to analyze properly. Okay, yes. So just remember what is hyaline change. Hyaline change may be asked, so it has once asked, I remember it has been once asked in university as a short note question, because there is not much more to write, but still you write about the hyaline change. Okay, just mention these 2 points, just mention these 2 points, and then you write about what to say, the rest of the things. Okay, yes, that is the intracellular accumulation, why it is happening, what are the factors, all those stuffs. Coming into glycogen, again you know glycogen storage disorders. Yes, what are the stains? Here you have to remember the 2 stains. Yes, one is PAS, and another one is best carmine. Out of that, which is most specific for glycogen? Answer is best carmine. Okay, PAS will give what color? Yes, this is why I taught you stain first. Magenta color. Fine. Yes. Coming into pigments. We have exogenous pigments, we have endogenous pigment. Exogenous means from outside. We have called workers pneumoconiosis, anthracosis, that is accumulation of black color pigments, tattooing, all those are examples of exogenous pigment. Endogenous pigment, yes, lipofusin, which is an insoluble pigment, also called lipochrome or a wear and tear pigment. Fine. It is mainly derived as a result of peroxidation of polyunsaturated lipid. That means here comes the question. Which of the following is an indicator of free radical injury? It has been once asked, which of the following is an indicator of free radical injury? The answer is lipofusin. Sometimes lipofusin won't be there, lipochrome will be there. Sometimes that also won't be there. You have to go for wear tear pigment. I hope things are clear for you. Yes. Fusin means black. See, you can see in this picture, it is a cardiac muscle. You can see cardiac muscle which are branched. Okay, they are cardiac muscle. You have to identify. You can see, red, brown, yellowish brown color. They are lipofusin. Fine. See, this is electron microscopy. You can see the deposition of lipofusin. Okay. Yes. Then melanin. Melanin. Okay. It is a brown black pigment formed as from the tyrosine and all. You already know that. It is an only endogenous brown black pigment. Okay, yes. We have another black pigment. What is that? Alkaptonuria, homogenistic acid, uchronosis. Okay, hemosiderin. Hemosiderin is golden yellow to brown in color. It is actually one of the storage form of iron. Okay, whenever there is a condition like hemochromatosis and all, there will be excess iron and which will be deposited in organs like brain, liver, everything. Okay, and what is the stain? Here comes the question. What is the stain? Like in case of hemosiderosis, everything, what is the stain we will use? Yes, can anyone tell what is the stain we are using for hemosiderin? Prussian blue. Pearl's Prussian blue. Actually, this color is produced by ferrocyanide. Okay, yes. So rest everything you can go through chapter stain. See, bile, modified Fauchett's. That is the stain. You will get what is the stain? Emerald green color. Okay. Then coming into question, what is calcification? What is calcification? Abnormal deposition of calcium in injured or non-injured, because we have 2 types of calcification, pathological classification and non-pathological or metastatic classification. Pathological classification is called as dystrophic calcification. How you will remember? Dystrophy starts with dystrophic calcification. Okay, dystrophy starts with D. D stands for dying. That means in dying or necrosis tissues, dystrophic calcification occurs, and in normal we have metastatic calcification. Okay, NM, remember like this, normal NM. So that is dystrophic and metastatic calcifications. In normal tissues, metastatic calcification, dying tissue, dystrophic calcification. Don't confuse. Dystrophic calcification, I have told in areas of necrosis. Fine? Yes. So you will see calcium deposit. I told you calcium combines with fatty acid to give chalky deposits. Yes, all those things you can write here. Fine? Yes. What is the morphology? What is the morphology? Okay, what is the morphology? Okay. See, you can see here, this is an aortic valve. This is an aortic valve. One second. See, this is an aortic valve. Okay, this is a valve of an aorta. This is a valve of an aorta. Okay, I am drawing the boundary here. See, you can see some plaque. You can see some plaques here, whitish plaque. They are nothing else but what? Aortic valve calcification. Aortic valve calcification, which is a type of dystrophic calcification. Okay, this is the aortic valve calcification. This patient is having aortic stenosis. Okay, so there is decreased blood supply to this region. So as a result, what will happen? Ischemia, necrosis, finally calcium deposition will happen, and this is called as dystrophic calcification. So what is then, of course, atherosclerosis, everything we have this dystrophic calcification happen in place. And remember, in dystrophic calcium, the serum calcium level will be normal. The serum calcium level will be normal in dystrophic calcification. This is a very, very, very important thing. Whereas in metastatic calcification, the calcium levels will be increased. That means what all examples you know for hypercalcemia, you can write for metastatic calcification. Okay, that is the reason. Simple way. Okay. So in normal hematoxylin eosilin staining, how the calcium salts, they will appear basophilic, amorphous, or sometimes a clumped appearance. Okay, yes, you can see something called as heterotopic bone. That means when you observe the slide now, you will see that there is a new bone formation. New bone formation at frequent areas. Actually, it is not a bone. That is why we call it heterotopic. Bone is usually found in only specified areas. The calcium deposits. But since this calcium deposit is found in some other area other than the bone or other than the area which is usually usually found, we call it this as a heterotopic bone. We call it as a heterotopic bone. Okay. Yes. Fine. So we can see masses like this. Okay, that is the calcium deposit. That is why it is called as heterotopic bone, because it looks as if we are seeing a bone. Yes, here comes a very, very important question. This calcium will what? Aggregate like this. Okay, this calcium will aggregate like this to form some concentric lamellae. This is mainly made up of calcium, and this is what we call it as what? Like it looks like a spring onion, no? Spring onion. It looks like a spring onion. They are called as Samoma. Samoma body is very, 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 very important. VVIP is a VVIP. You will learn this till the last chapter in pathology. You will learn this Samoma bodies. Samoma means what? Sand. It looks like grits of sand. It looks like grits of sand. In histopathology, you will see like this. Okay, I will show you 1 second. We will see the Samoma bodies. Don't worry. You should know how to identify the Samoma bodies. Yes, wait, we will see this. See, very beautiful Samoma bodies. You can see here, very beautiful. You can see, Samoma bodies. Yes, you can see what? Spiral shaped concentric lamella. They are nothing else but calcium deposits. Here comes the question: what all conditions you can see Samoma bodies? Write down the list. Number 1, meningioma. Number 2, papillary carcinoma of thyroid. Number 3, papillary carcinoma of other organs. Wherever we have papillary carcinoma variant, we can go for that. Then number 4, serous cystadenoma of ovary. Okay, these are the various area. You can see yes, you can see hypercalcemia. Okay, yes. Then of course papillary thyroid carcinoma. Yes, we have something called as prolactinoma. Yes, I forgot that. In pituitary. Okay, just we have, I'm writing 5, prolactinoma. Okay, yes, prolactinoma. Fine, you can just go through this picture. I'm going to download this picture once again. I'm going to here Yes, 1 second. We will insert it here. Yes. Okay, see what is it? It is actually a Samoma bodies can be asked as a question. Okay, it can be asked as a question. See, they are round microscopic calcification, concentric lamellated onion-like appearance, fine, as a result of calcification in pituitary gland, in prolactinoma, papillary thyroid carcinoma, meningioma, glucagonoma, okay, and papillary serous carcinoma of ovary or serous cystadenoma of ovary. All these are the conditions where you see what Samoma body. See the picture, okay, how it looks like. I told you, the calcium will appear like blue amorphous granular structures. Now you are going to tell what are the stains for calcium. Von Cossa, which is most commonly used, whereas most specific sarin red. Here the calcium will be red in color. Here the calcium will be red in color, where here it will be black in color. Von Cossa. I hope this is very clear for you. Yes? Okay. Metastatic calcification occurs in normal tissue where there is hypercalcemia. So from that it is clear. I told in dystrophic calcification what is the serum calcium level? That is normal. Here the serum calcium level is increased. That is in case of increased parathyroid hormone due to parathyroid tumors, ectopic secretion of PTH. Whenever there is bone tissue resorption, multiple myeloma, leukemia, breast cancer, Paget disease, vitamin D related disorders, sarcoidosis, okay, just remember all these names, vitamin D disorders, okay, all those stuffs, or in case of renal failure as a result of secondary parathyroidism, okay, chronic renal dialysis, milk alkali syndrome, all these conditions, because all this will finally increases the serum calcium and there will be calcium deposition. And remember, here comes the question, which are the regions in the body where the metastatic calcification mainly affect? It principally affect the interstitial tissues of gastric mucosa, kidney, lungs, systemic arteries and pulmonary veins. Very important. It has been asked in PGI. This question has been asked in PGI. It was a multiple answer type question. That means in a single question you will have more than 1 or 2 or 3, or sometimes they will give some 5 options. That 5 options may be also correct. So what? Interstitial tissues of, remember this, interstitial tissues of the gastric mucosa, kidney, lungs, systemic arteries and pulmonary veins. I hope things are very clear for you children. Yes? Okay. Fine. Then coming into cellular aging, it is as a result of decrease in cellular function. Why we are getting age? Because our function is going to decrease. There will be accumulation of some pigments, all those stuffs within our body, okay, which will have some drastic impact, to our body. Yes. So the cellular aging, it is an short note question for you. It may occur as a result of number one, DNA damage, which finally leads to defective DNA repair, mutation, cellular aging, or due to telomere shortening. Telomeres are present on the end of the DNA. They helps to maintain the DNA replication. When the telomere shorten, cellular replication decreases, cell loss happens, cellular aging. Or defective protein homeostasis, decrease in normal protein, increase in misfolded damaged protein, which will further causes cellular aging. There are some factors in our body. See, I am just 21 years old. I am not getting aged very easily. Why? There are some adaptations to prevent premature aging. What are they? Decreased IGF or insulin signaling, decreased TOR and sirtuins. Okay, we will see each of them. Don't worry. Okay. So we have a condition. That is what we call it as Werner syndrome. That means due to a defect in DNA helicase, which is DNA helicase is very important for DNA binding and replication, there will be premature aging. And also in some other disorders like Bloom syndrome, ataxia, telangiectasia, all these things again we will see in genetics chapter and already have learned in biochemistry. Okay, this is Werner syndrome. I will show how the person in Werner syndrome will look like. Don't worry. Okay, Werner. Yeah, here comes Werner. Here comes. Okay. See, premature aging. There is See, this is Werner syndrome. Premature aging. Okay, these are the pictures of Werner syndrome. Premature aging. Okay. Then I have told you, what are the factors? Cellular senescence. That is, I have already explained to you, that is telomere attrition. What is the importance of telomere, telomerase, everything you already know. See, yes. Here comes the question. The enzyme telomerase, it is expressed in germ cell. It is present at very low levels. It is present at very low levels in stem cells and almost absent in somatic tissue. Here comes 3 MCQ question, children. Telomerase enzyme, 3 MCQ question. Highest telomerase enzyme is in germ cells. That is testis ovary, yeah. Lowest, you can say, in stem cells. Absent in somatic cells. 3 points. 3 points. Okay, yes. Then, due to defective protein homeostasis. Fine, yes. That is rapamycin. Rapamycin is going to inhibit mTOR, that is mammalian or molecular target of rapamycin, which will increases the lifespan. Okay, so this is mTOR. You will learn in pharmacology also, that is mammalian target of rapamycin. So mTOR inhibitors are going to increase the lifespan. Then we have insulin and insulin-like growth factor. Okay, they are again going to prolong the life. Okay, yes. And sirtuins. What are sirtuins? Sirtuins is an important question. They are NAD-dependent protein deacetylases. Again, around 7 types of sirtuins are present in our body. Okay, and what is their important function? They will increase the longevity by inhibiting the metabolic activity. They reduce apoptosis, stimulate protein folding. They increase insulin sensitivity and glucose metabolism. So, sirtuins are the current target for treatment of diabetes. So, IGF, insulin-like growth factor 1. Actually, it is mainly produced by the pituitary gland. It is actually going to mimic the insulin, and hence what? It is going to, as I have told you, how rapamycin will inhibit mTOR and prolong the longevity. Here the IGF-1, okay, IGF-1 is also going to inhibit inhibit the mTOR, and it is going to increase lifespan. Cellular aging. Okay, and senescence. It may be a short note question for you. Just go through all these key points and write about sirtuins. Okay, write about sirtuins. What are they? They are NAD-dependent protein deacetylases. Sirtuins, insulin-like growth factor, and mammalian target of rather is rapamycin. That is TOR. All these are going to, okay, this picture, I have told you, this TOR, insulin, yes. So all these are going to counteract the aging. So decreased IGF signaling, decreased TOR, and sirtuins. All these are the important factors which counteract aging. So please go through all these points. Okay, and of course from this chapter there are a lot of high yield facts are there. Okay, like I will prepare some other video regarding only the high yield facts, or just like a revision video for this chapter, because we have lot of small things to remember. Okay, that I will prepare a video and I will upload soon. Okay, here we have the Sandomas bodies. Of course, there is a condition called as asbestosis. Okay, there will be calcium and iron. Okay, which will form like long spicules will be present, which have a dumbbell shape. Okay, like this. Okay, dumbbell shape like this. We call it as asbestos body. That and all we will discuss. Okay, if we discuss each and everything, it will take lot of time. In the corresponding chapters, we will discuss. Just remember Sandomas bodies. Just remember what are the conditions, how it looks like. Okay, just focus on this picture, all the stuffs. And cellular aging and senescence. Stem cells have very low. Germ cells maximum, somatic cells almost absent. Telomerase enzyme. Okay, just focus on this region. Okay, and so I think with that I'm saying goodbye. Thank you. We'll see you in next session. I will be uploading 2 videos. One, cell unit of health and disease, high yield fact, HIF, and number 2, cell injury, high yield fact. Please watch for your next or INISET exam. Not only for those exams, it will be a revision video. I will be revising all salient points in 2 chapters.